The people who are at risk, it does seem to be more of a problem with people with hemorrhage. It's definitely more of a problem with the bigger strokes, this total anterior circulation stroke, so people with big middle cerebral artery strokes. Older, frailer people seem to be more at risk of progressing. And say physiological abnormalities. And although we don't have good trial evidence here, what most stroke units do is just try and make sure that physiologically people are as near normal as possible. There have been some trials looking at using automated monitoring where you, in fact we did one that was published this year, where you have somebody connected to a continuous monitor for 72 hours. Our experience was we picked up lots of abnormalities, but we didn't really pick up a lot of difference in the clinical outcomes. But our nurses are good at doing standard assessment for people, so we already had a good baseline of care. Second one to mention, neurological one, is post-stroke seizures. Now these aren't all that common, but you will see quite a few in a year of looking after acute stroke patients. Quite often they're focal in nature, just affecting one part of the body, and occasionally they're quite difficult to sort out. These seem to be, again, more common in the bigger strokes, in the hemorrhagic strokes. Those that impinge on the cortex seem to be more common. I say sometimes it could be quite subtle, non-convulsive. You've got somebody who's just a bit drowsy, but usually they're pretty obvious. And the treatment is really with the standard anticonvulsants. But I think it's just important to be aware that if somebody is having odd periods where they're just a bit knocked off, then to think of post-stroke seizures. The next group I wanted to look at was the cardiovascular ones. Now, there's a whole load of cardiovascular complications that have been reported, many of which are don't necessarily interfere with recovery. I mean, a lot of people will have, say, asymptomatic atrial fibrillation or ectopic beats, or even slow and fast heart rate, but that they're essentially asymptomatic. Clearly it's important to pick these up if we've got to think about secondary prevention, but they don't often interfere with recovery. Other more serious ones like myocardial infarction and cardiac failure, we see that quite a lot, of course, because strokes occur in a group of people who are at high risk of cardiovascular disease. There has been a fair bit of work done. This slide just shows some a study done looking at trying to identify if you could predict who got serious cardiac events. And these are, I don't know if people are familiar with these. I'll use with these one or two of these. These are called receiver operator curves. Has anyone heard of that? Apparently they were originally developed to train radar operators. And what they were doing was they were adjusting the settings of radar equipment so that you get the best balance between a sensitive machine that picked up a signal, but not so sensitive that you picked up false positives. And with these plots, the further you are, the line goes up to the top left-hand corner, the nearer you are to a perfect prediction. And the line across here is where it's just chance. You toss a coin and you would get as good a result. So these predictive scores weren't that good. They were okay. But the things that tended to identify people at risk of serious cardiac events were a history of heart disease, diabetes, renal impairment, and again this severe stroke and abnormalities on the ECG. But I think this system's probably not good enough to use in clinical practice in any useful way. There's a similar area of work now looking at troponin, and I'm assuming in Australia you use troponins to try and identify people with a limited heart attack. And the curious thing in acute stroke is if you just do troponins on everyone, you'll find about 1 in 5 people have a raised troponin. And it's associated with ECG abnormalities, and it's more frequent in people with, in older people and people with a history of cardiac disease. So it seems to be a real phenomenon. The real trouble is we don't really know what to do with this result because these people are usually asymptomatic. So it's an area of research interest, but maybe not so much, not so clear what we do clinically. In terms of the cardiac complications, we do tend to, the treatment is, there's nothing particularly special about treating people with stroke, and they tend to be treated in the conventional ways. In some countries they're advocating continuous cardiac monitoring of acute stroke patients, but again it's controversial because it's not always clear what you do with the information. If somebody has asymptomatic arrhythmia, what do you do with that information? So it's an area where practice tends to vary. Now, really moving on to the two main areas I think of interest to this audience, I would think, is starting off with complications of immobility. I didn't mean to downgrade this. This is for some reason the formatting slipped. But this is, I think, is one of the really big areas, and the areas where the multidisciplinary practice is so important. And in this category we've got the infections, venous thromboembolism, falls and pressure sores are probably the main ones. And in this table, this is from our cohort study, we looked at how often people had any features of these complications when they were in hospital in the post-discharge period and then in the longer term. And you can see some of these were really surprisingly frequent. And beginning with the infections, these are, I think, among the most important group to be aware of. This table here shows results from a review of studies of infections and really looking at whether the presence of an infection in a stroke survivor was a risk factor for them dying or doing badly in terms of recovery. And particularly with chest infections, most studies suggested chest infection was really an important factor in poor recovery. Urine infection, it was less clear, but chest infection definitely was bad news. And of course, chest infection's not uncommon. We found in our study that about 1 in 12 patients in any 1 week would have a chest infection. I think it's maybe a bit less than that now, but it's of that order. So you'll usually have someone on your stroke unit who's got a chest infection. The causes, I mean, why do stroke patients get this? There is some belief that there's some kind of immunosuppression in stroke. I think that's quite controversial. I think much more credible is firstly the risk of aspiration of oral fluids. And of course, even if you put someone nil by mouth, they'll still have saliva that will and oral secretions that are loaded with bacteria that will be going, they'll be at risk of aspirating. And also immobility. You know, if you have somebody who's immobile and in bed, it's much more difficult to clear chest secretions, and the physios here will all know that, and much more likely to get opportunistic infection. This is a result from a study, another of these receiver-operator curves, as you can see. This was done by one of our speech therapists, Cameron Sellers, and he followed up about 400 acute stroke patients, and they looked at who was at risk of getting an infection. And we found 5 things came out as independent predictors. Older age was one, any speech impairment, definitely any water swallow test failure, or we use more sophisticated swallow assessments, and they all came up with the same thing, that any impairment of your swallowing was a predictor. The more severe stroke, again the same story, more severe stroke, higher risk of complication. And also we found that those with confusion were at a higher risk as well. And many other studies have looked at prediction of infections, and by and large they come up with the same thing. Older age, impairment of swallowing, severe stroke consistently come through. And I'm sure this audience are well aware of the issues around prevention and management. And the conventional care, as far as I can see, is it's around good positioning, getting people up sitting if possible, preventing aspiration, good management of swallowing, good fluid balance. And the sort of monitoring is essentially just good clinical monitoring and being aware of the risk of infection. And if someone's having episodes of hypoxia, if they're a bit paraxial, to be thinking chest infection. And the treatment is very conventional antibiotic therapy. But the important thing is to be alert to the risks. And again, I'm sure this audience are aware, but this I think this is one area of really important in multidisciplinary practice, that being aware of the swallowing safety, the care needed in feeding people, the risk of aspiration. And I think although this is common practice, it's important to recognize there's actually some really quite good trial evidence. I expect you're familiar with this study. This study came from Australia. I'm afraid it was Western Australia, but Australia anyway. And they did a really nice study of comparing the normal care, which is where stroke patients were referred to speech therapy for assessment and management of swallowing, versus a systematic approach. They actually did the systematic approach at 2 levels of intensity, but it was the same approach, that they had a series of compensation strategies, dietary modification, practicing swallowing, and basically it was the same program in both those groups. And I'll just combine the 2 groups, but what they found in their trial was that among these people who were at fairly high risk of infection, the systematic approach to managing swallow and managing diet had a significant reduction in swallow complications, significant reduction in chest infections, and a non-significant reduction in deaths. And I think this really just reinforces what the belief that most of us have in stroke care, that the importance of being alert to the management of swallowing.